Thank you so much. I'm happy to be here. I'm Ray. I'm a faculty member at the University of Alabama at Birmingham. Um, Also a trained exercise physiologist. So if by any chance during this talk you feel the need to stand, please do so. So we'll jump right in. So starting with some background. So frailty, as Christine mentioned yesterday, you'll probably hear about 17 other definitions. So it's a geriatric syndrome that describes the vulnerability to different stressors. Has a number of health implications for individuals aging with HIV, and with the ART, there's this decrease in HIV-related mortality and an increase in these age-related morbidity, things like falls, hospitalizations. And with the accelerated aging in this particular population, frailty may occur at earlier ages, and the transition from pre-frailty to frailty occurring at a faster rate. Now, the most common assessment of frailty is we know it, we love it, we use it, is well recognized and has utility. It's the Fried Frailty Phenotype. It's comprised of 5 characteristics: slowness, weakness, you probably said this in your sleep last night, unintentional weight loss, exhaustion, low physical activity. And these components here, where you have 1 to 2 individuals considered pre-frail, 3 or more frail, none of those robust or non-frail. But what we know is that these components can independently and synergistically impact overall health. So what does pre-frail look like for an individual? It might look different for me, it might look different for you. And these individual characteristics rarely occur in isolation, especially when it comes to the deterioration of physical function. So for this particular project, we wanted to examine the prevalence of these unique frailty clusters and evaluate the association of these clusters with cardiometabolic disease in older individuals living with HIV. And we used CNICS. Now, you can see the inclusion criteria up there: individuals at least 50 years or older on ART with complete clinic data from at least 1 visit on all frailty characteristics, and complete vitals. Now, CNICS is the Center for AIDS Research Network of Integrated Clinical Systems. It's a longitudinal, nationally representative clinical cohort here in the United States. It integrates and harmonizes clinical data from electronic medical records. So for this study, it was cross-sectional. We used data from 2011 to 2021. I think the unique part is the frailty measured in CNICS. So there was a modified frailty phenotype using patient-reported outcomes in CNICS. I was grateful to be part of that paper that came out. So 4 components of frailty in CNICS. So they have unintentional weight loss measured by the HIV symptom index, low physical activity using the Lipid Research Clinics questionnaire, fatigue, poor mobility, and weakness is not assessed. I'm no clinician, but I think it would be a little difficult during a routine HIV care to measure grip strength during that visit. And here we are the cardiometabolic conditions that we assess. I won't go through all of them, but these are the ones: cardiovascular disease, hypertension, diabetes, so on and so forth. And right, what do you mean by these clusters, right? So I think this is the unique part of this particular study, right? So we clustered these things based on the 4 components available to us in CNICS. So we have a 1 characteristic clusters, 2, 3, and 4. And from here, we just wanted to determine the prevalence estimates of these clusters within this cohort, as well as we did an adjusted odds ratio, adjusted for age, sex, race, and the medication in this particular population, and we used our non-frail individuals as our reference group. And just rolling on through into the results, as you can see at the top, just drawing your attention to, we had about 5,000 people. Pre-frail was the most prevalent in this cohort, followed by robust and non-frail, which is very common in CNICS. Our average age was 61 years old. Our frail individuals were younger. It was mostly male, predominantly white. Now at the bottom, we also have study site information. So CNICS has 10 sites now. Only 7 of those sites had available data, so we're missing data from Vanderbilt, Miami, and Hopkins. So here is just the prevalence of these frailty estimates, just showing the most prevalent in this frail category. We have the combination of fatigue, poor mobility, and low physical activity. And those who are frail, fatigue, weight loss, poor mobility, and low physical activity. I should mention that these groups are mutually exclusive, so if you're in one group, you can't be in another. In the pre-frail group, we have poor mobility as the most prevalent, followed by low physical activity, and then a combination of poor mobility and low physical activity here. So this is a lot for a chart. So just drawing your attention to those in red, and I'll just orient you to, there we go. I'll just orient you to the top of the table here. So these are the cardiometabolic conditions that we assessed. These are the clusters on this side. The first two are how we measure frailty in the typical sense, right? So the categorical sense. And as you can see, I think we can appreciate that there's an increase odds of these cardiometabolic conditions across these for both pre-frail and frail individuals compared to the robust. But I was very interested to see in this poor mobility, low physical activity group, this trend is common throughout, but in the cerebrovascular disease component, right, this little area, there's a 3.11 times greater odds of cerebrovascular disease in this particular group, this particular cluster. And I have the data for the frailty, but for the sake of time, if you want to chat about it after, come and find me, we can talk. So I thought this was very interesting in this aspect, but what does this mean, and why do we care? So the Frailty phenotype has been modified in several ways, right, which has led to some unique findings. This is just another one of those ways to see how these things cluster. And as we know, the presence of frailty is heterogeneous. So these components may differ, impact our health differently, depending on what's present. And so it's important to understand how each of these things, so with this clustering method, it's important, it can allow us to implement targeted interventions on these particular things to implement to routine care of individuals aging with HIV. And then also assessing this clustering in routine care can be beneficial for risk stratification and reducing overall adverse health outcomes in individuals aging with HIV. Here's my funding. And thank you to CNICS and all the patients of CNICS and my team here. So thanks so much.